our 11 o'clock thesis, and after this, we'll have lunch for 30 minutes, I think, and we'll be back at 12:15. So this is Vaylin. Had a great time talking to Vaylin about her thesis all year. It was kind of crazy that she changed her topic like halfway through the year or something like that, right?
I still made it in time.
It still made it in time. I was very, very worried for a while, but she's done a really good job. And these are her words of acknowledgement. I should have started about 5 minutes early to read her acknowledgments because they're very long. But she says, I would like to thank God for the grace to begin, the endurance to continue, and just enough health to still be functional by the last page. Thank you to my parents and brother for tolerating the light radiating from my room every night at 2 a.m., mostly without complaint, but occasionally with, for much longer than any of us expected. My advisor, Miss Viola, whom I jokingly asked after a biology test, how do you define a plant? And after a long discussion, hit me back with, how do you define a living being? Leaving me ruminating, gave me the idea for my third proof. My panelists, Ms. Bea and Mr. Zorn, for taking an interest in this work and with whom I look forward to discussing. Please give me grace. Thank you to the rhetoric teachers, Mr. Wade and Ms. Maymay, for their grace in every deadline, including this one, which I just wrote last night. The shadow advisors and teachers who sat with me through earlier drafts and practice runs, my friends who peer-reviewed my arguments and stayed up peer pressuring each other to do the thesis, and at some point decided that we needed a break and created a farm fittingly named Screw Thesis. And lastly, to my own restless mind, which, when it was not actively derailing me, left behind genuinely useful counters and ideas that Claude could never generate. Debating my inner demons in my document's comments, I'm pretty sure that it has enough word count for it to be its own essay. Recovery, as I argue, is built on relationships. So, as it turns out, is a thesis. Her title is, I hope I read that okay. Her title is Hard Pill to Swallow, the Half-Life of Psychiatric Recovery. All right, let me get the timer set. Do you want to see the timer, Vaylin?
Sure.
So I'll get the timer set up, and I'll tell you when you can start. All right, you can start when ready.
The pill was supposed to be easy to swallow. That's the entire promise. That buzzing inside your head, would you believe that in a moment it could all go poof? So here you go, take it with some water, same time each day, smaller than a fingernail, lighter than a coin. How hard can it be? Oh, was that a list of side effects as big as a blanket? The side effect of antidepressant is even more depression? No worries, kid. We can always up the dosage, or there's plenty of more pills to choose from. Psychiatry has given us the power of recovery in the palms of our hands. All you have to do is swallow it. So you do, because who doesn't want to get better, right? Same time each day, every morning, never missed. The buzzing is quieter now, but now so is every other tone. You report your symptoms to the doctor. He says, okay, you're getting better. Here's your prescription for the next month. You pick up the pill. You shake the doctor's hands. You drove on your way back home, but it doesn't feel like you're holding the wheels to your own life. You uncap the orange bottle the next morning. The small pill rests heavy on your hand, and you think, is this all there is to recovery? The buzzing is quieter, sure, but what do you fill the quiet with? Disturbances of the mind have been explained through philosophical, biological, and supernatural lenses, hence treatment followed accordingly. The scientific revolution came with Descartes' distinction of the mind and body. The third revision of the DSM replaced psychoanalytic language with a symptoms checklist. Within a decade, antipsychotics effects were discovered, and hence medication has been psychiatry's primary instrument. The WHO revealed that 1.1 billion people globally live with a mental disorder. Let me emphasize, that is 1 in 7 people in this room. In England alone, antidepressant prescriptions have risen by roughly over 40% over the past 5 years, reaching more than 400 million prescriptions annually. In low and middle income countries, 80% of those in need of mental health treatment receive none at all. You may expect this scarcity to protect against over-medication, but instead it perpetuates since psychosocial care are not available. Before we go further into the topic, it is important to distinguish between the two terms. Over-medication is what happens to the patient. Drug prescribed too early, too long, too much, or in place of something more appropriate. Over-reliance is the systemic preference of pharmacological treatment over other forms of intervention. It is important to note that neither term deems the use of medication inappropriate for all cases. For acute and chronic condition, medication may be life-saving. Thus, the argument is not against the medication itself, but the reduction of care to medication as its endpoint for pharmacological treatment that has been clinically warranted. Mental disorders are one of the few conditions where the pinnacle of recovery is the patient's active participation itself. When the body is broken, say a bone, the patient heals whether or not they understand the fracture. When the mind is compromised, healing does not happen to them, but through them. It is the glue of recovery that makes symptoms relief adhere. Without it, recovery is just a managed dysfunction that crumbles as easily as a fracture that was never set properly. Therefore, the mental health care system must be reoriented towards integrative care, as dominance in pharmacotherapy is structurally produced by design rather than clinical need, biologically constrained to symptom suppression, and philosophically insufficient to address the complexity of a human being. First, over-medication is the structural result of foundations that funnel mental health care system towards pharmacological solution. The current psychiatric framework is structurally designed to produce over-medication. Like a fire left untreated will keep growing, each revision of the DSM expanded the flammable area. Each revision since the DSM-3 lowered diagnostic threshold as a preventative measure, leading to false positive and the medicalization of experiences that fall within the spectrum of human emotion. Evidenced by the 150% increase in diagnosis since the 1980s in America. Economic and political incentive reinforce and accelerate over-medication, further tipping the already uneven scale. If the mental health care system was on fire, pharmaceutical firms poured fuel to the fire and sold the warmth as medicine. Pharmaceutical firms have been documented funding disease awareness campaigns that expand diagnosis criteria, a phenomenon known as disease mongering. As chair of DSM-4 Alan Francis said, never once have pharma created a product that exceeded the effectiveness of the drugs available 60 years ago, supported by multiple meta-analysis concluding in no significant difference in efficacy between newer and older antidepressants during short-term treatment. Insurance company further pushed the agenda as insurance require a diagnosis and routes 80% of antidepressant and anti-anxiety prescription through general practitioner with limited psychiatric training. While structural and economic forces set the system in motion, it is societal pressure that continued the momentum of over-medication, reinforcing the system from the bottom up. Society does not merely supply the fuel to the fire, but convinces people to seek out the warmth, punishing those who fail to maintain societal standards. Where failure to meet standards was once a transgression against external norms, the freedom the 21st century brought us taught us to internalize the distress and thus the remedy as well. Secondly, the biological mechanism of psychiatric medication constrains them to symptom suppression rather than etiological treatment, inevitably causing neurobiological changes that generate dependence, relapse, and comorbidities. What was easy to discover turned out to be hard to understand, and what was hard to understand was prescribed anyways. Psychiatric medication simply suppresses the observable symptoms while the underlying pathology is left untreated. Decades of neuroscience have established the pharmacodynamic profiles of the drugs. However, there's a gap in correlating their molecular dynamics to their therapeutic effect. The first antidepressant and antipsychotics were discovered through serendipity from antihistamine derivatives that cannot be confirmed through eliminative induction since the central nervous system is dynamically open and complex. There's no denying that some mental disorders have established biological aspects, but assuming that a drug's action reveals the mechanism of the disease is a post hoc fallacy equivalent to concluding that all headaches are caused by aspirin deficiency because aspirin relieves them. Despite the DSM acknowledging the non-etiological root of its diagnosis, drugs are still prescribed to target mechanisms that remain hypothetical, and psychiatric medication cannot be the etiological treatment. Chronic use of psychiatric medication produces compensatory neurobiological changes that cause a side effect, tolerance, and dependence. Psychiatric medication stimulate neurotransmitter across multiple interconnected circuits, inevitably affecting system rather than a single pathway. Stimulating neurotransmitters prompts the brain to counteract the effect of medication through receptor desensitization in order to maintain equilibrium. Hence, side effects are not just common, they are inevitable. Continued stimulus of the neurotransmitter also produces neural structural changes, shaping the baseline around the presence of the drug itself, creating physiological dependence. When that keystone is removed, the established equilibrium collapses, creating withdrawal effects that frequently resemble the original disorder, making it difficult to distinguish from relapses. What looks like evidence that the patient is still in need of medication may be, in many cases, be evidence of what the medication has done to them. Furthermore, prolonged pharmacological treatment carries downstream consequences that increase risk of relapse and comorbidities. A 2024 meta-analysis found that roughly 45% of patients relapse within 12 months of discontinuing antidepressants. Prolonged pharmacological treatment may also contribute to the emergence of other disorders, known as comorbidities, through compensatory neuroadaptive changes. Such comorbidities may also concern potential irreversible complication, including further cognitive impairment, creating a feedback loop that produces the conditions the drugs were prescribed to address. A final, and perhaps most fundamental reason why over-reliance on medication must be stopped is that human distress and recovery cannot be equated, understood, or treated adequately from biologically reductionist models. Biological reductionism does not account for the fact that human beings are ontologically complex. It frames psychological distress as merely neurochemical malfunction, perpetuating the reliance on medication. So, what does it mean to be human? Aristotle believed that human beings are ontologically complex, having each of its 2 feet in different ontological domain, one in the realm of nature and the other in the defined realm of intellect. Imago Dei, we are the image bearers of God. To bear the image of God is to inherit capacity, moral agency, and relational nature. Reducing us as the image bearer is a categorical error about what kind of thing a human being is. Engel's biopsychosocial model further uncovers that human health are produced from interaction between psychological, biological, and social factors, hence treating patients as a person with biography, not merely a system with defects. Patients report that recovery coming from a pill is hollow and unsustainable. Thus, if 204,000 years of science cannot unify the dimensions of humans, then by what authority does psychiatric practice proceed as if that reduction were accomplished? While medication can play an important role in reducing psychiatric symptoms, its dominance in treatment model risks displacing the deeper process required for recovery. Viktor Frankl, writing from a concentration camp, argued that meaning is the primary human motivation, and the loss of meaning itself is a form of suffering that no drugs can address. A pill can reduce the intensity of an episode, but it cannot help a patient understand why they feel empty. Someone can clear every clinical benchmark and still not feel better. Furthermore, nearly half of patients who improve on antidepressants relapse within 12 months of discontinuation, since medication was managing their symptoms. But behind the mask of recovery, the blue remained unchanged, while every other color was dimmed until the distinction itself disappeared. Furthermore, pharmacotherapy holds no demonstrated superiority over psychotherapy, undermining the justification for its dominance in treatment models. A 2025 meta-analysis of 650,000 patients across major mental disorder concluded in no significant difference in efficacy between psychotherapy and pharmacotherapy. When efficacy is equal, ethics becomes the tiebreaker, and medication-centered care fares poorly against all four pillars. Non-maleficence is compromised by significant side effect, dependency risk, and comorbidities. Beneficence is undermined when symptom suppression is treated as the ceiling of care rather than its floor. Autonomy is not served by a system that defaults to the most convenient intervention rather than the most appropriate one. And justice is violated when pharmacological treatment rules over psychosocial care, not because it's superior, but because it's cheaper, faster, and more reimbursable. Therefore, the over-reliance on pharmacotherapy is not a clinical conclusion. It is a corrupted structural habit in need of deliberate correction. Considering continuous use prevents relapse, some might argue that psychiatric medication can be a sustained long-term solution by correcting chemical imbalance. In this sense, taking antidepressant is just like taking insulin for diabetes. Both antidepressant and diabetes are marked by symptoms. Both are lifelong conditions that can be managed but not cured. Both cannot be rid through sheer willpower alone. And both can be managed but not cured. However, most psychiatric medications cannot target a specific pathological site in the brain like insulin targets blood glucose. Moreover, diabetes is not managed through insulin alone, but paired alongside dietary modification, lifestyle intervention, and regular monitoring. The analogy, if anything, supports the case for combined treatment. Even in schizophrenia, a disorder where neurobiological dysregulation is most clearly established, medication alone proves to be insufficient. After 4 years of integrated therapy, 55% of patients partially recover, and 10% of those fully recover. Others may say, when efficacy is comparable, patient preference should be the deciding factor, and some patients will reasonably choose medication over confronting the source of their distress. While autonomy is integral, preference for medication may reflect avoidance of discomfort rather than an informed judgment about long-term recovery. Psychotherapy is designed to help a patient work through distress, not merely suppress it. Compared to pharmacotherapy, psychotherapy offers a structured therapeutic relationship which helps patients identify and change behavior patterns, learn coping skills to fare with future challenges, making recovery adhere over time. Psychotherapy excavates the ground to build a strong foundation rather than just placing the architecture of recovery on top. So, the argument has been made, not against the medication, not against the patients themselves, not against the clinicians who prescribe it, but against the assumption embedded in every layer that the pill is where the treatment is supposed to end. Peeling back those layers, we first found that the system produces over-medication not through error but through design, through its diagnostic inflation, economic incentive, and societal pressure. Biology was examined next, mechanism targeting symptom suppression rather than its root cause, causing dependence, side effects, and comorbidities. Looking into the person behind the biology, we found that the person is irreducible to neurochemistry alone, meaning identity and connection are not appendices, but the substance of recovery that makes symptoms relief adhere. A conclusion reinforced by the data itself. When pharmacotherapy and psychotherapy produces equivalent outcome, it is important to refer back to ethical guidelines in which pharmacotherapy fares poorly. The pill was supposed to be the easy part, and it was. The pill still small, still lighter than a coin, smaller than a fingernail. It has not changed. It will not change. What needs to be changed are the hands holding the pills. The hands that creates the guideline, the hands that sign the prescription, and the hands that are taking it. That hand holds something that cannot be prescribed. The capacity to grasp meaning, to shape identity, to reach out, pick up a phone, dial your friends and family, to build connection. It is what the Christians have called community. The recognition that to bear the image of God is to be constituted by relationship, and that no one can be restored in isolation from people who they were made to belong to. Every psychiatric drugs have a half-life. the time it takes for half of the substance to leave your body. It is measurable, predictable. You can calculate the hour it begins to fade. What you cannot calculate is when or if the disorder will. Symptom suppression diminishes from the moment it begins, because it was only ever half of a whole recovery. So, the pill did its job. The buzzing got quieter. On some days, you and your friends will laugh so loud that the buzzing won't be heard. On other days, you'll be so caught up with work that you forget that it's even there. But what will you do when you're alone and you hear it again? That low hum underneath everything. You have a choice. You can pop another pill, switch to a different one, or you can stop running from it this time. You can walk towards it, find out where it's coming from, what's causing it. And then, when you're standing right in front of it, what do you think you'll do? How are you going to spend the rest of your life with it? That answer is yours, and no prescription can fill that in for you. Thank you.
All right. Good job, Vaylin. The panelists today are Mr. Zoran and Ms. Bea. Let me give it to Ms. Bea first.
Okay, good morning, Vaylin. Congratulations first. And basically, I love your topic. I love the way you deliver. And then I love all of the analogy that you use. Okay, so I start with the first questions. You talk about this generally worldwide, right? I'm just curious about specifically that happened in Indonesia. Do you know the ratio between the treated mental illness compared to the untreated or undiagnosed mental illness, specifically in Indonesia?
Okay, as I have explained previously, thank you, Ms. Bea, for the question. 80% of those in low and middle income countries are not treated at all.
Okay, continuing that, meaning that the over-reliance on medications, is it actually already happened in Indonesia, not yet, or will not happen?
As I explained previously as well, the undertreatment of psychiatric medication does not negate the occurrence of over-medication. Both of them can happen simultaneously. Since resource is scarce in Indonesia, pharmacological treatment becomes the only available interventions compared to the psychosocial interventions. Hence, the gap between the supply and demand causes the system to further rely on medication rather than addressing their root cause through psychotherapy or social care. Thank you.
Okay, yeah. I'm about to talking about the demand. So, gini, you mentioned about the demand of the antidepressants and all of the medications is higher in the high-income countries, right?
Yes.
Nah, I want to highlight about this. I think the high demands of the mental medications is not because of the pharmaceutical is making the trend, but it is because of the people that start to aware about that. So I think the over-reliance on medications is inevitable, and I think it is a common thing that happens. It is the pharmaceuticals not intentionally make it. Since, let's say, example, vaccines. Back then, we don't know about vaccines. Back then, people care more about how we treat the infections than preventions. But once the awareness of the peoples rise and they think that it is important to prevent rather than cure, the vaccines also becomes the demand of the vaccines increase. The same thing, like the mental care medications. How do you think?
Well, it is true that the growing rate of diagnosis is not inherently bad. It is good that more people are getting more aware of mental disorders. However, unlike biological disorders where it has a clear biological disorders, biological dysregulation, mental health disorders cannot be prevented, as in we don't know what's causing it. We cannot predict what it happens, how it happens, and when it will happen. Hence, the quote that prevention is better than cure does not really apply to mental health, since if you try to lower the diagnostic threshold, it will inevitably lead to false positives.
No, my question is about if we talk about the demand of the medication is right now, it's not because of the pharmaceutical industry intentionally did that. It is because of the increase the people's more aware about this. It's not because of the pharmaceuticals industry wants to take benefit on it.
Okay, it is good that people are more aware, but not every disorder have to be treated by medication. Hence, like the thesis still stands that medication is not the first line intervention that should be given for all mental disorder, regardless of their severity and symptoms.
Okay, thank you. Next. So, I disagree with your statement about the marketing that done by the pharmaceutical industry. So, do you know that the government strictly regulates the advertising for the category of the drugs, just like the antidepressants, as we know that it is not OTC, it is the types of the drugs that needs doctor prescriptions, and there is no advertising for that. Thus, the pharmaceutical industry has no power to persuade people to take it. Yeah, so it is purely because of people's more aware about that. We know that more people need that medications. What do you think?
Wait, can you clarify the question, Miss?
Okay. So you mentioned that the pharmaceuticals industry take benefit on this, and then they justify that they don't take benefit on this because they spend money more on the markets than research. Right now, I disagree with you, since for this type of the drugs, there is no marketing, since the government strictly regulates. In Indonesia, we have peraturan dari BPOM, so that really they don't allow the pharmaceutical industry to create advertisement related to the drugs like this, like all of the antidepressants, let's say.
Okay, well, maybe it's true that the pharmaceutical firms cannot advertise the medication through the patients itself, and the patients have to get their prescription from the clinicians. But I think that pharmaceutical firms can obstruct the side effect and dependency risk of pharmacological interventions, since it is so normalized that it's used across a lot of different cases. So it's kind of normalized to the point where the side effects and dependence become normalized.
Okay, my last. So one of another disagree with you. So you mentioned about the discovery of these medical drugs. So you mentioned that most of the psychotropic drugs were discovered accidentally. I think it is a good thing, not a bad thing. Since if we talk about the history, back then there are so many discovery in biology especially, that it is actually accidental, like the CRISPR or penicillin, let's say. It is not a bad thing. It is a good thing. And I think if you mention the reasons the discoveries happen accidentally is the drugs is not strong enough to question the quality of the medicines. Yeah, you mentioned that if it is not discovered by this hands, so it seems like you questions the quality of the medicines. But I think it is not, gitu. Since there are so many things that happens back then accidentally like this.
Okay, I agree with you. From my research, penicillin were also discovered by serendipity, and it is also used to prevent bacterial infections in the World War II. To say that medication discovered through serendipity should not be used is not a claim that I want to make. While it is true that medications can be life-saving, we conclude that the mechanism of the drug's action, we concluded to the mechanism of the disease itself. While it is true we don't know yet the mechanism of the disease, the hypotheses like monoamine hypothesis for depression is like extrapolated through multiple disorders. Hence, that is what I'm against, not against the use of medication itself, since it was discovered in serendipity.
Okay, thank you. That's more makes sense for me. Okay, that's enough for me, Mr. Wade.
All right, Mr. Zorin.
Okay, thank you, EO, for the performance and your speech, and of course the thesis as well. Yeah, I must say that I've read everything, and I find that your refutatio have shattered some of my previous questions. Okay, that being said, though, know that this doesn't come from a biological point of view. My questions, this come from, I think, some personal or sociological point of view. Okay, because well, I personally take you as my panelist because I have colleagues and friends who went through a lot of stuff in their life and they resort to medication to survive, right? So my first question, maybe I'm leading with a different slant here, but I think there's some sort of a maybe slippery slope in your arguments that say that these pills are kind of like a monopolized by a certain pharmaceutical, and then say if you take it one, you're gonna be addicted and everything. So of course, in your paper, you say that you're not against arguing. You're not arguing against the use of drugs, but you say that it's not supposed to be the end all be all, right? Yeah. And here's the thing, maybe Ms. Piola can correct me, but as far as I know, psychology's main job is to ensure that the person maintain a good quality of life and that the person is functional, right? Whether the person believe in God or not, it has other part of the question. So what would be the case for individual who have a psychological problem? He went to a psychiatrist, get an Adderall or quetiapine or whatever, and then that's it, it's done. So that proof that the medicine in itself is okay, right? It's not harming or anything, and the person is not into this whole addictive lies of his life, gitu. So what do you think?
Okay, thank you, Mr. Zorin, for the question. The prolonged use of psychiatric medication, while like the first like time use of it, the short-term use of it, is not against. It's not something that I argue against. But the long-term use of it, like for example, using like Adderall or like Prozac for an indefinite amount of time, is something that I refute against. That is because, as I said before, the prolonged use creates like dependency, tolerance, and side effects, and that we can like solve the problem through like psychotherapy. So, although like you can use like drugs for short-term treatment, you should also combine that treatment with psychotherapy. So eventually, the person can like taper off the medication and fend off on their own.
Okay, so that goes to my next question. What's the line? What's the line that the person must take from just taking the drugs into like maybe some psychiatric counseling and whatnot? What's the line? Because I know some people take the drugs and help them to survive from some suicidal episodes, right? So what's the line for them to maybe reduce the dosage and like continue with some integrative care that you mentioned?
Okay, for the line itself, really varies for the person, the disorder itself, and like how they respond to treatment, how willing are they to cooperate in therapy. For, like you said, suicidal crisis or like acute and chronic, it is important to ensure the safety of the patients themselves, to ensure that they are not a harm to themselves or others. After that, after they have like stabilized, we can integrate it with psychotherapy so they can like adhere, like their recovery can adhere over time.
Okay, now my next question will be about the psychiatric types, psychopharma types. I think you call it psychopharma, right? Basically, pharmaceuticals that help with psychotic episodes or everything. There are many types, right? You know, antidepressant, anti-anxiety, and maybe a lot of stuff. Which of these drugs or which of this category of this psychopharma that you deem in your study to be actually do more harm than good? which one that's supposed to be banned and why?
I don't think any of them inherently should be banned because they do save lives. Can you clarify the question?
So, as far as I know, yeah, in my study, in my understanding, you have antidepressants, antipsychotic, musables, and many other things, right? And if I'm not wrong, you can actually buy them online in so many shops. There are places that actually give you the access to these drugs easily, right? You don't have just to get it from some what do you call it? Some doctors. Some places actually sell them as vitamins or stuff. That being said, people tend to actually abuse these very drugs, right? And that makes the case that the government isn't really doing a good job in handling this regulation, right? So what you can do to change the regulation so that people will be more into this integrative care? Because as far as I know, people are still addicted to these drugs and they have means to obtain these drugs. Even if they are medical drugs, they are not, sorry, narkoba gitu ya. But at the same time, the government isn't really doing a good job. What should the government do about it?
What should the government do to prohibit
Drugs.
these drugs
Or maybe
of being abused?
encourage the use of this integrative care, because I see people abusing it.
Okay, I think the current problem why integrated care has not been implemented right now is that the funds that is needed to go to psychotherapy is like much greater than the funds that is needed for pharmacological treatment. Hence, I think from the government itself, they can, from insurance companies and government as well, they can reimburse or like fund more psychosocial alternatives.
Okay, I have two last questions. My third question had to do with maybe Indonesian context. So as I know, maybe I'm wrong, yeah. We inherit our psychotherapy or other things from the West, right? We inherit the drugs, the medicine, the procedure, the therapy from the Western context. You quote, of course, Engel, Franco, and many other names. I was wondering in your study, because we're Indonesia, yeah, do you have like any local wisdom or local perspective that connects with your audience better as an Indonesian than this, Western ideas or Western sources? Like you mentioned Engel, a biopsychosocial thing, but do you find some local alternatives to this that we Indonesians can count on?
Like the theories themselves, or
The theories or some framework or maybe some local sources that actually encourage this encourage this integrative care.
okay, for the sources themselves, none of them I've sourced like from the theories from Indonesian psychiatrists or psychologists, but from the data and from talking around to the counselors and like Dr. Tia, I found out that in Indonesia it is also a quite prevalent concern that like in Indonesia, like BPJS doesn't provide any insurance at all for psychosocial alternatives. Is that what you're asking?
Actually, it's not really clear yet for me, but I think I can just go with the last question. Okay, this is actually because I used to be a Bible teacher on 10th grade, right? Yeah. So here's the thing. Throughout the Bible, Jesus healed a lot of people, right? Do you remember what he always said to the people that he just healed? Whether it's the woman who had like her period problems, whether it's the one that is demon possessed, or the prostitute that caught with her adultery. What's the thing that Jesus always do to the person that just got healed? He always say one thing.
I don't follow, mister. I'm sorry.
So for the person that Jesus always heal in the Bible, he always give like last one prescription for the person. He or she has to do something. Do you remember?
I'm not sure, mister.
Okay, it's okay. Maybe it's like a gotcha question, but basically he always say, please go back to the place that you came from. Go back to the society, go back to your family, go back to your current context. And I think that's something that I'm actually expecting from the previous question. We have a local wisdom, we have a great deal of like local culture that basically say that when a person is like having issues, you gotta accompany them, make them not lonely and everything. And I think that's an additional insight that you can put in your paper if you like, the local wisdom thing. But other than that, I think I have an excellent case, and I think I can go with Mr. Wade. Thank you.
Okay, I have just a quick question. It seems to me that this whole idea of overprescribing medicines for these sorts of mental illnesses is just part of a much bigger problem, which is overprescription in general. In other words, if I have a cold or flu or something like that, I go to the doctor, and sometimes I'm hoping for antibiotics, but maybe the doctor sometimes should just say, you don't need anything. Go home and rest and let your body take care of it. But instead, I usually come back with about 5 prescriptions of things the doctor says to take, right? And I think that there's this idea somewhere that's been culturally created that when you go to the doctor, you need to get medicine. And the doctor feels some sort of pressure. Is there a pressure from the medical world to give you medicine, right? And I think that's really the case. Is that true? What do you think?
I agree with your statement, mister. I feel like more doctors should be assessing the patients in more a holistic kind of manner. And like, if medication is not the best course of treatment, then clinicians shouldn't be pressured to prescribe, but instead they should like refer to other alternatives.
Are there, so it seems to me, and there's some mental illness that I'm in, like my daughter has OCD, right? And so when she first went to see a doctor, the first thing they did was they said, well, let's first talk about therapy, right? And then when medicine was eventually prescribed, there was also an idea that we need to regularly see the therapist and see how these things are going and whether you need to keep on the medicine or not. Is that the kind of thing that you're suggesting, or what?
Yes, alongside integrative therapy, it's also important for the clinicians, like the psychotherapists and the pharmacotherapists, to work in tandem. So, like, when the medication like opens a window for treatment, the psychotherapist can like come in, or like when the treatment has like progressed well, then maybe they can discuss on whether or not to continue the use of the medication or not.
Yeah, because in America, and it's probably the same all over the world, but the psychiatrist can prescribe the meds, but the therapist cannot, right? So the therapist wants to do therapy, and he may say, let's get you to a psychiatrist as well. But the psychiatrist, he's not usually involved in therapy, he or she. So it's sort of like, how do you maintain that communication to make sure the treatment plan is going to work?
Well, it is hard to like maintain connection since both of them will eventually like have their own motives. But it is important to work like with the ethical guidelines of non-maleficence and like work in the best interest of the patients themselves. Also, while it is hard, but I suggest that you source both of like the psychotherapist and the pharmacotherapist from like the same clinic so they can work in tandem.
Okay, time is up. Good job, Vaylin. Okay, great. So what we'll do is we'll meet friends and family over here and panelists and advisor over here for photos.